ladies, it's Menopause Barbie here today, bringing you menopause management your way. And I'm bringing you today a gynecologic menopause specialist. So what you see here today is a talk with the person who does menopause specifically. And this is Dr. Nina Ali. Thank you so much, Dr. Ali, for coming today.
Thank you for having me.
And we just are going to teach my viewers what a menopause clinic is all about. So you run a menopause clinic, which means you manage menopause.
Yes.
So what led you to do that?
So I'm a general OBGYN, and I practice within an academic practice. And as I went through my training, this was something that I just became more and more interested in. Early in my training, I actually thought I wanted to do fertility work because I was interested in hormones and how all that works. And the more I kind of learned about it, sort of the flip side of, when the hormonal change happens later in life and all the medical things that are involved, and especially kind of the lack of attention that that area of our specialty receives made me more interested. And so that's kind of how I...
So it's your passion, just like it is
mine. It became my passion. It wasn't something I knew going into OBGYN, but it sort of developed as I met the patients.
Oh yeah. And you are in the Texas Medical Center, and that's the largest medical center in the world. But are there menopause clinics worldwide, people who specialize in just menopause around the world?
Yes. So as you very well know, being an expert yourself in this field, that the number of women who are living in menopause is growing just as our population is aging. And so those women really are, I think, now starting to reach out more to seek help for their menopausal symptoms. So we do have a few larger organizations like the North American Menopause Society, ASRM, and so these groups are really building their clinician practitioner base, and there's specialty people who have such interest. So I think we are seeing more menopausal practices pop up. Certainly they're not meeting the need of what's out there yet, but yes, all over the world you will find practitioners with this interest, so they should be sought out for women who are
they're becoming more and more common.
Yes.
And so a woman who wants to work with a menopause specialist should look for people who practice nothing but menopause, and they can find them on websites and in societies like North American Menopause Society and others that are around that will tell you who out there is practicing just menopause.
Right, and as you so the North American Menopause Society is the one that I would really recommend patients look to. They have actually developed a certification program, so practitioners can prepare, make sure they're well informed on the latest evidence. They take an exam. I had to take the test a few years ago, and then you receive a certification, and they make sure that you maintain, staying up to date on what's the newest.
You're cutting edge. All the finest, latest things about menopause.
And that database is on their website.
Yeah. And as a menopause specialist, are you able to spend more time with your patients talking about menopause and educating them about various things that they need to know?
Yes, I certainly do. I mean, one of the things about menopausal patients is that it's not a 10-minute conversation.
Oh God.
It takes 10 minutes. It takes 10 minutes to really just kind of open up and sort of get into what's the crux of the situation. So, in our practice, we've really made an effort to carve out the time. So when a new menopausal patient comes to see me, she's allotted a full hour of my time.
And hopefully she's only 40 years old at the time, because it's going to take the next 10 years to work through everything.
And even, and thereafter, we try to make sure that we have enough time. But it does require, a lot of time, because there's sometimes many factors involved.
Well, usually by the time they come to you, there are a lot of different things that they want to address. And one of the biggest complaints is that they don't get enough time with their physicians.
Absolutely.
And I always say, well, physicians don't have that kind of time. And especially if they aren't experts in menopause.
Right.
So, what's your very favorite thing about working with menopausal women?
That is a hard question. But I think my favorite thing is the patients. I mean, every patient I see comes with a unique experience and story. And so my favorite thing about care of our patients is that It's not kind of cookie cutter.
Yeah.
It's not, I really don't know what I'm walking into when I walk
Right.
into the room with a new patient.
Yeah, you're tailoring everything to them.
And so for me, it's kind of mentally challenging as well, because I have to think, okay, you know, what could this be? What do I need to figure out for this person? And so that's my favorite part of it.
Right.
It's not, it doesn't go according to check boxes and guidelines. So
no. It's so much more than that.
Yeah.
Everyone's so unique, and it's so great to make sure that you're tailoring everything to each person's needs, wants, wishes, desires, fears, whatever they are, and get it right for her at that time in her life. And that's where my passion lies too. That it's not like, hey, everyone should do the same thing.
Absolutely, yeah.
Do you think more of your patients come to you from the very beginning of their menopause, or do you find that more of them have already tried to work with other healthcare providers in whether alternative and complementary or traditional medical arenas, and come to you after that? Which would you say is more numerous?
It's actually a pretty good mix.
Is it?
So where we are in the medical center brings in all kinds of patients. So I have quite a few patients that are cancer survivors, because MD Anderson's right next door.
Yeah.
We are, in line with major medical, hospitals that have all kinds of patients. Catchment area is large. So, but I would say most of my new patients are people who have sought out a specialist, who probably have tried seeing one or two, providers or their own therapies on their own, and have had struggle with it, and then have sought out somebody to sort of help them sort through that.
Yeah, I would think so. I would think so, because there's a lot of dissatisfaction out there. And when you get a patient like that who has already tried to manage your menopause with another kind of provider, what kind of feedback do they give you about those experiences?
Well, it's mixed. I mean, patients generally, women, they love their doctors. Oftentimes they've been taken care of by the same OBGYN who delivered their babies, and they've seen year to year, and who knows them well. And so it's not that they're necessarily dissatisfied with their provider. It's just that this area in particular, and it's not even an issue with the provider, it's that something that from an education standpoint, we have not emphasized in people's training.
Absolutely.
So the providers are not comfortable because they weren't really taught how to manage and how to nuance
It's
that
so
part.
true. I remember about an hour on menopause education during medical school. I remember an hour. And then in my residency in OB-GYN, menopause patients just kind of rolled into everything else, but we didn't have a special rotation or a special time where we did just menopause medicine. It was just always kind of lumped into everything else. And what you and I have done is said, wait a minute, we think menopause deserves a specialty and to be an entity in and of itself without having to be just part of everything else. And I think that's the biggest difference when you go to a gynecologic menopause specialist. They're people who just feel like menopause is the world. We want to do everything we can for menopause.
Absolutely.
Yeah. And when you get patients, do you feel like they're already fairly educated when they see you, or is the lack of education a big part of what's lacking?
Yes. So again, that is kind of all over the page. So I will have patients on one end who are extremely well informed and who have read studies and who bring me information that I hadn't been aware of yet. So I'm learning from them, and we're kind of conversing together. There's also patients who really don't know what's going on. And so we talk more about, what is normal physiology for women during this transition. And then on the third category, I'd say there's a lot of misinformation. So there's women who've been getting information from, yes, and I know your viewership is very well informed, so they're not in that category.
No, but I tell them
However,
how much misinformation
there is a lot. And just like,
everywhere.
the internet is a wonderful resource for getting good information. It's also very easy to put up non-credible information. That's a good way to put it. So, so then we need to talk about, what have you heard that maybe is not correct? What do we have information for? And then there's a lot of things we don't know yet in medicine. So we're having to say, okay, I can't tell you for sure that this is going to be a benefit, but since it's likely not harmful, why don't we do a trial? So we do a lot of kind of working with
Yeah.
that sort of information.
Yeah, that's great. And so you believe, as I do, that when a patient educates herself, gets the information, and learns the kinds of things I teach them, that they are much easier to work with, and that they benefit much more from the visit, because the level on which you're able to interact is completely different.
Absolutely.
Yeah.
Absolutely.
Yeah.
Yeah, because it's not, we're not living in the era of the doctor mandate where you come
no.
in with a clipboard and
No.
say, you're going to do this. It's really a conversation, and it's such an improvement, because I think that patients need to be informed. What we do have really great evidence for, like we know, because it's been well studied in thousands of people, that if you do X, Y, and Z, you are going to get a benefit in 5 years, 10 years, the rest of your life.
That's right.
And there are a lot of things we don't have that kind of science behind. So I think a woman needs to know that we think, based on what we know, this would be helpful, but there's different levels.
Sure. And do you feel like the patients that you see still have a whole lot of misconceptions about menopause?
So much.
I find that there's more misconceptions out there than anything.
Yeah, well, it's funny you mentioned kind of the part about training, because I was doing I actually started my residency in 2002. And 2002 was the year that the WHI findings came out. And so for that block of years that I was in training, nobody was on hormones. Nobody.
Everyone
because we thought it was going to cause heart attacks and strokes and breast cancer. So everybody stopped. And that was the years of my training. So everybody who trained in my era really didn't get any education on that, other than that it's bad.
And now that this many years have gone by, they've gone, oops, sorry, we misanalyzed the data.
So
it's all back to where it started. What we told you wasn't really true.
And so I think for those women who had to stop so abruptly, they had to go to resources outside the medical arena to figure out what are we going to do? We're not getting it from our doctors anymore. Let's go elsewhere. And so that kind of led to this parallel, therapy realm that was outside of our med. So we kind of did a disservice to women at that time. And as we're learning more, we're kind of, as you said, the pendulum sort of swung back, and we're getting more and more, kind of better guidance for people.
Yeah, and do you feel like that thinking, that report about the WHI has really still hung around and really continued to underlie women's fears? Do you feel like they haven't really come around to realizing that was a complete bit of misinformation?
Right. Well, the problem with that is that the WHI was the largest study. It had so many women involved. It was, well funded. And that kind of study is not likely to get repeated again.
I know.
So now we're left with working with the information we have from that study and gleaning what is useful. So it's not that it's totally, thrown out.
Right.
But now that we look at, let's actually look at the women who are early in their menopausal transition and how they did, and then compare that with a separate group of women who was 60, 65, 70, and how they did, because those people are different people.
Completely different people.
Just like, so it makes sense. You can't just lump everybody together. So I think it's still useful.
Oh, sure.
Because that's what we have.
Yeah.
And it was well intended. I mean, finally, after decades of
All
only
studies are
studying,
well intended.
After only studying men, finally somebody thought, let's find out what would be helpful for women. So you have to applaud at least that effort. However, you're right. It did a lot of disservice, because what got the press was kind of that initial report.
So the press didn't come back and say, "Oh, well, we need to we need to retract what we said."
Exactly.
That's the problem. So, what would you say is the most common complaint you see from your early perimenopausal patients? What's their biggest complaint?
Well, I think a lot of women, so perimenopause can start at a variety. So it can even start in your early 40s.
Of course.
And all of us who are in our early 40s,
You're not in your early 40s.
I certainly am. Think that we're still 28, And so don't want to hear about, anything that has the M word in it. So I think one of the hardest part is getting your mind wrapped around that. You're not,
so
your body is changing and that's normal and natural.
Yeah.
And the first signal that women often have with that outside, of the kind of the physical stuff we hear about, hot flashes, is that their periods start changing.
Yeah.
It's not as predictable as it used to be. Changes in metabolism can be very disturbing.
That's one of the biggies.
Early things like hair loss. I mean, some of these things that you wouldn't necessarily put on a medical history form, however, can be very significant.
Well, I think that the early perimenopausal bothersome complaints have mostly to do with the things that affect our feelings of sexuality. I really do. I think the weight gain, the things like hair loss, hot flashes because they're embarrassing. I think those are the things that end up bothering women the most at the very beginning.
Yes.
They start feeling like, wait a minute, I'm not as sexy as I used to be, and it's such a big emphasis in our society.
Absolutely. So we're not allowed to really age. So you know what I mean. So there's kind of these, and so especially when that process starts, it can be. Yeah. And a lot of women, especially, and again, we see a lot of professional women, they're kind of just getting going in their careers. They may still have young children, even though they're, may have started later. So, that's not really kind of what they're prepared for.
And what about when early post-menopause comes about? What changes about the primary complaint at that time?
So early post-menopause, that's, in my mind, the periods may have actually stopped. Right. There's more sleep disturbance. I feel like I'm talking to a lot of women about how to get a good night's sleep and how to, again, continue. I always talk about setting yourself up for continued health. So most women, up till that point, may have never had any medical issues. They've never really needed to see a doctor other than to get their birth control. And now all of a sudden there may start being some lab abnormalities. There may be some higher cholesterol. There may be some thinning of the bone. And so really at that point, I like to talk about, okay, let's manage your symptoms, because the symptoms really tend to still be full-fledged. But also, let's do the preventive things so that
for the
10, 20 years from now, you're not saying, oh, I wish I'd kept my bones stronger.
Exactly.
Because you can't do that.
And see, I think that kind of thing is one of the biggest differences in what you're going to get with a gynecologic menopause specialist versus family practitioner, general practitioner, internal medicine doctor, osteopath, whatever. I think there's some practitioners who focus right on the symptoms, and that's really all that's on the radar. And you see, in my mind and in your mind, we're looking at this big picture of what menopause means to the rest of your life.
Right.
That's a completely different mentality. And I think the way you work with that and the way you plan for that is so different than just saying, well, let's get rid of your hot flashes.
Right.
And then when you come to late postmenopause, you get a whole different set of primary complaints. What are those?
Yes. So late postmenopause, again, I mean, a lot of some of the things I mentioned continue. One thing I do tend to talk more about is pelvic health and kind of maintaining vaginal health, and how that's important and that's safe to do long term. A lot of women, feel very hesitant to continue any kind of hormone replacement after a certain age, but at least vaginal estrogen therapy is considered very safe long term. So we talk about that. We talk about maintaining pelvic floor strength, and again, those health things that are so important. So heart disease, cancer prevention,
and osteoporosis,
staying active, keeping your muscles strong. So women after menopause, probably more so than men, tend to lose their muscle mass, which decreases metabolism. And so exercise that not only keeps the cardiovascular part, but weight training, keeping your muscles strong. So those sort of things are kind of.
So you really have a complete protocol in your mind about what you need to make sure you address with patients at different ages, even if they aren't coming in with those complaints. You're ahead of the game. You know what's coming down the road for them.
That's what we're trying to do. Yes.
Yeah, that's great. Yes. Well, I think that's our responsibility.
Absolutely.
And I think it's one thing for a patient to have a complaint, but I think it's our responsibility as healthcare providers to prepare them for their futures.
Yeah.
What would you say is the most difficult menopausal symptom to treat?
There are many. There are many that are challenging, but I would say because it's so common and we've done not a great job of finding effective therapies, for me it's libido.
Sex drive.
So yes, because it is so very common and at every stage actually.
Sure.
And you know, we keep hearing about things that are sort of in the works, things that may be effective. But there really hasn't been the sort of robust research and studies and trials that we really need to really treat this issue well, because it is a quality of life issue.
Absolutely.
And you know, it's sort of dismissed sometimes as something important enough to kind of warrant the grant money and that sort of stuff to have the good studies. But a lot of women talk about libido, how important that is to them. Many women are actually, you know, the kids are out of the house. They want to have that intimacy with their partner.
They're like, yay, we've got a place for ourselves. We can fool around anywhere.
And then he's, you know, he's taking the Viagra or the whatever else, but you know, what's there for her? And so we try some things that are, you know, not FDA approved per se, but you know, we have to talk about.
But that's the other thing that I think when you're working with a gynecologic menopause specialist, that's the big difference. We play with that stuff. We find something to work, even if we have to do something that's, quote, off-label, something that's not approved for a specific purpose. And the reason we have done that is because we see how much absence of sex life affects people's quality of life.
Absolutely.
And so it becomes an important health issue, actually. And so, yeah, I think that's a big difference there, too. What about the long-term health risks? Do you find that a great deal of your focus is on the long-term health risks, preventing things like cardiovascular disease, heart attacks, osteoporosis, and Alzheimer's, breast cancers, things like that?
Yeah, absolutely. So I do spend a lot of time talking with my patients about those things. I think as women, we tend to, I mean, a lot of women are very worried about breast cancer, so we talk a lot about, you know, cancer prevention and proper screening and appropriate things there. The area sometimes for more education is the cardiovascular risk, because women tend to minimize the importance of the cardiovascular risk factors. Women present differently than men. They often don't have the classic symptoms that of the crushing chest pain, of the, you know, radiating down the left side and all of that stuff. Women present very differently. Their EKG changes are very different. And so it's really important that women have appropriate screening, that they manage their blood pressure in order to really kind of maintain good cardiovascular health long term.
And what you said about the fear about breast cancer versus heart attack is so real, because women are scared to death of breast cancer, but they don't realize that heart attacks are the most likely thing to get you. The risk of heart attack is greater than everything else put together once you're menopausal. And women don't seem to know that. And so the focus on what's important has been kind of shifted. And so I'm so glad to hear that that's one of the big things that you talk about. And that's the kind of thing that's going to be different when you're working with a menopause specialist versus someone who isn't a menopause specialist. They may not be geared that way. And what do you think? Do you think that's the thing about which menopausal women seem to be the most unaware? Do you think it's that?
I think that's one of the major things. As far as what has the highest impact, that is one of the major things. So we certainly talk about that. And then the other thing that I try to emphasize that women are aware of is just the importance of diet and exercise. And I know it sounds very, very simple. And so there's kind of like a, you know, zoning out sometimes of it. But really, you know, maintaining good bone strength, maintaining your cardiovascular health, maintaining good mood. And mental health. So we know that, you know, someone who exercises regularly, it's like being on an antidepressant in terms of what it does for your mood and your outlook. We know that women who have breast cancer and have survivors of breast cancer, if they exercise daily, they do better than women who are on tamoxifen and other chemo prevention. So it's that beneficial.
It's huge.
So having strong muscles. All of those things help maintain good health. So I always think that's worth a little chunk of time.
I agree.
To kind of re-emphasize it's not, shock breaking news that exercise is good for you, but sometimes, we all forget, and we all spend even though I think that I'm an active person, I spend most of my day in a hallway seeing patients and in front of a computer typing my notes. So how much am I actually moving during my day? And how you can kind of work that in.
It's not dedicated exercise. I think there's a huge difference in saying, well, I walk a lot at work. That's not exercise. Exercise is when you take yourself out of the environment of having other things impair your ability to simply focus on the exercise and listen to your music or do whatever it is that you want to do when you're only exercising. And I think there's a luxury to that, but I think when it comes to the benefits, they're completely different. Because it stimulates different chemicals and hormones in your body. Yeah,
it helps you sleep better. I mean, so many positive effects of it. So I think that kind of is worth some extra attention to.
Yeah, I think that's so true. And what is the most popular management option of your patient population? Would you say it's hormone therapy or something else?
I wouldn't say necessarily there's something that's more popular. It really, depends on what they come in for. But in terms of sort of your classic symptoms of menopause, the hot flashes and night sweats all night sort of thing, then I usually do a combination of estrogen and progesterone. I prefer to use transdermal estrogens because we know that there's a decreased cardiovascular risk based on the latest studies that we have. And so I offer patients options in terms of what's the best way to do transdermal. So there's patches, there's sprays, there's gels, there's a vaginal ring. What is easy for you? What is going to be best tolerated and able to maintain. And then usually I will do an oral progesterone at bedtime because that kind of has a little bit of a sedating effect, and we want people to sleep well. It makes the whole next day so much better. So we want to use that side effect of the progesterone. So that kind of combination. So it is a bioidentical regimen. So it doesn't have to be particularly compounded, and so that's kind of my first line for most people, unless they've tried things before or are on something particular. And then once they've gotten to a good place with that, we see, do we need to add something else? Do we need to cut down your dose? Do we need to go up on your dose? And so that's where sort of the fine tuning comes in.
And also, as a gynecologic menopause specialist, you can do the surgical procedures for them that might happen as a result of menopause or aging, such as pelvic prolapse, things that might happen as a consequence. And so you're able to do all of that for them.
Yes, we are able to do all of those things, and I'm very fortunate to practice in sort of an academic setting where not only do we have specialized pelvic floor surgeons for more complex cases, we also have pelvic floor physical therapists that help me a lot with my dyspareunia patients. We have psychiatrists who help with the mood and anxiety changes. We have nutritionists. We have kind of a lot of things that we can get people plugged in.
It's really, really wonderful. But do you also work with alternative and complementary practitioners if a patient wants you to?
We do. So we have some providers that are, I wouldn't not necessarily specialized, but have taken care of many women with similar symptoms. So we have an acupuncturist that we send patients to who's in the community, and some of those other type things as well are available.
And do you ever have a patient who comes to you first and says, okay, well, I don't want to take your hormones and all that stuff, and then leaves, goes and works with whoever, alternative, complementary, this person, that person, and then returns back and says, you know what? After being out there and seeing what the comparison is, I'm coming back to you because I realize that the difference in the care I'm going to get and the level of your expertise is so different. Do you see a lot of that where they come back?
We see a lot of that, and that's okay, and that's fine. So, and what I also see is people who come in just for the information. Like they want to know, what is your opinion? What do you think about my situation? What do you feel about what I'm taking right now?
Very good.
And so we will talk about that, and that is fine. And I don't, no one should feel pressured to start something that they don't want to. And it is completely okay to try some alternatives and see. Because Or even though
Yeah.
there may not be, the evidence, let's say, for certain, herbal remedies,
Yeah.
there are patients who feel benefits. So
It's all about peace of mind.
So who's to say for that individual it's
Yeah.
not okay
Yeah.
to do that?
Yeah.
So I think as long as a woman is well informed, she knows
Right.
what her options are.
Right.
That it is okay to try to figure out what's the best
Yeah, I
option
think
for
it's so
you.
great. I think it's so great that you're open-minded about the fact that it's not a one-size-fits-all, and that there are different people with different preferences. And I preach the same thing, that my opinion doesn't matter. It's my patient's opinion that matters.
Yeah.
And each woman should think for herself and decide that she knows herself better than anyone else does, and give herself peace of mind by doing what works for her.
Yes.
Both her comfort level and her body's satisfaction, right?
Yes, absolutely.
I thank you so much for doing this. I really can't tell you how wonderful it is to inform women about your presence out there, and about the fact that they can find a specialist, someone who just does this. We eat, drink, sleep, love this stuff. And
Our favorite thing to
it's
talk
our
about.
My favorite thing in the world is
talk about.
menopause,
Well, it's so fun for me to be here, and you're such a great resource for so many
Thank you.
people, so
Oh,
I appreciate that.
I appreciate your participation, and I know the viewers do too. Thank you so much, Nina.
Thank you.
Okay, everybody, I hope you enjoyed that. I will see you again in a week. Take care of yourselves. Be well. Bye.